My name is Abbey. I'm the Director of Clinical Research at Texas Retina Associates in Dallas, Texas. I'm here at ARVO 2024, where I'm presenting on the GALE open label extension study, looking at 36 months of treatment with pegcetacoplan for the treatment of geographic atrophy. So the GALE study essentially is a continuation of the 2-year phase 3 clinical trials of Derby and Oaks. And in those clinical trials, patients were treated either with monthly pegcetacoplan or every other month pegcetacoplan or monthly sham or every other month sham injections. Once they completed 2 years of that trial, the patients were able to roll over into the GALE study. And in the GALE study, the patients receiving monthly injections from Derby and Oaks continued with monthly injections of pegcetacoplan. Those receiving every other month dosing also continued with every other month dosing of pegcetacoplan. And then the sham groups, the monthly sham group would be able to roll over into a monthly treatment with pegcetacoplan. And the every other month sham group was able to cross over into the every other month dosing with pegcetacoplan. So all the groups were then treated starting at the beginning of the GALE study. The GALE study lasts for 36 months, so that'll give us a total of 5 years of data for some patients who have been involved in both trials with long-term treatment with pegcetacoplan. And we see that in the GALE data, in this right now we're presenting the first 3 years now of treatment, so the 1-year data with GALE now, that the treatment effect is increasing as time goes on with the injections of pegcetacoplan in terms of reduction of GA growth. So when we see at the year 3, the reduction of GA growth was 35% in the monthly treatment group and 24% in the every other month group at year 3. If we focus in more on the non-subfoveal lesions, these lesions that we know are a phenotype that tends to grow faster than, say, the foveal involving lesions, we can see in those patients that received monthly dosing at 3 years, they had a 42% reduction in GA growth and a 28% reduction if it was used every other month at 3 years. So we see a higher and more pronounced effect on reduction of GA growth in those faster growing lesions that are outside of the foveal center. We also did a little bit of a post hoc analysis with respect to severe visual impairment in these patients over the course of the 2 years of the Derby and Oaks trial. Severe visual impairment is defined by the WHO as vision less than 2200. And so if you look at the data in terms of development of vision of less than 2200, we can see that there was about a 38% reduction in the risk of development of severe visual impairment in patients who received monthly pegcetacoplan over the first 2 years of the trial. Another visual measure that we looked at was microperimetry, which I think is a very sensitive way to determine visual function in patients who have geographic atrophy, and we have previous studies that help to corroborate that. So in this post hoc analysis, the microperimetry data from the Oaks trial of the first 2 years of treatment with pegcetacoplan was looked at specifically for whether there was a loss of sensitivity, a complete loss of sensitivity in the central 4 and the central 16 macular loci on microperimetry. What that really translates to, the central 4 loci is the central subfield right at the dead center of the fovea, and central 16 is the entirety of the fovea, the sensitivity of the entirety of the fovea. And what you can see from this post hoc analysis is that there was a significant reduction in risk to complete what we call absolute scotoma, a complete loss of sensitivity in all 4 or all 16 of these areas by using pegcetacoplan. So to say it again, the risk to getting a complete loss of vision in the dead center or a complete loss of sensitivity on microperimetry was significantly less when pegcetacoplan was used as opposed to sham. Finally, we look at safety data in this trial, and we can see that after the initial 24 months, we have an additional year of safety data to look at with GALE, and we see that the GALE data was consistent with the previous Derby and Oaks data when it came to safety and adverse events. Specifically, we do see that there is still a slightly higher risk of developing wet AMD in patients who receive monthly as opposed to every other month dosing with pegcetacoplan. And then the overall rate of infection in terms of infectious endophthalmitis was 1 in 3,600 for the 3 years that we have data for. The rate of intraocular inflammation was 0.26% per injection. over the course of the 3 years of the study, and all of those cases in the study were mild to moderate and treated adequately with steroids. And then finally, there is a risk of ischemic optic neuropathy. That risk is 1 in 2,000 currently for the 3 years of data that we have. So just to summarize, we have a continuing increase in treatment efficacy over time with the use of pegcetacoplan over the course of now 3 years of data that we have to analyze. We see that the safety data remains consistent with the previous phase 3 clinical trials, and we do have these new post-hoc analyses showing that we are preventing severe visual impairment by using these medications in our patients with geographic atrophy.
What was the patient retention rate through the 3 years of this trial?
So in terms of the actual numbers of retention through the GALE trial, at least, we know that 83% of the patients who completed Oaks and Derby went into the GALE trial. And out of the last year of data that we have now in the GALE trial, we know that 92% of those patients have stayed in that trial since. So it's been pretty good retention overall.
With the increased risk of patients developing wet AMD, how does that increase risk for vision loss or other side effects with 2 injections for treatment?
That's a good question. I think so. The 3-year cumulative rate of incidence with monthly pegcetacoplan is about 19%. So about 1 in 5, again, over the course of 3 years, can convert to wet AMD with monthly dosing. But with every other month dosing, that rate is significantly lower. It's just below 9%. So personally, I don't actually treat patients monthly with pegcetacoplan, partially for that reason, but also because of, I think, it's too much of a burden on them as well to get monthly dosing for the rest of their lives. So for me, I prefer going closer towards about every 6 to 8 weeks, closer maybe every other month like we did in the trial. I think the risks go down a little bit more in terms of inflammation, ischemic optic neuropathy, and also the risk of conversion to wet. But if I do have a patient that converts, in my hands, which is I have had that happen actually, what I do is I just kind of separate their visits out and try to get them the most durable therapy for wet AMD possible early on, and then try to space out their visits as quickly as possible with the wet injections. But I do not do 2 injections on the same day. I think that that's difficult on the patient. It's difficult on our practice as well. And it's also logistically, in terms of getting reimbursed, I think it's hard to know whether it's actually going to get reimbursed properly by Medicare when you do 2 drugs on the same day. So for all those reasons, I think it's just not worthwhile to do it on the same day. But I do work it out that they kind of alternate their visits so they can come in and get one or the other. I feel comfortable with our current therapies that we have for wet AMD that I can usually get them out to at least 3 months eventually with and we're usually, in these patients specifically, when they convert to wet, we're catching it extremely early because we're following them so closely. We're either doing it monthly or every other month, right? So when we catch it early, they respond better and more quickly, and we can get them extended earlier too. So I try to get them extended as quickly as possible, get them on a durable agent, maybe get them out to once every 3 or 4 months on the wet as quickly as possible, and then I can do every other month dosing for them on the dry.
How long until this study is concluded?
The GALE study is actually going to go on for a total of 3 years. So what we're going to eventually have is a data set of patients who are receiving continuous pegcetacoplan for 5 years, beginning from Derby and Oaks all the way through to the end of GALE. Now, already we've had a few patients who have finished up the 5 years total of treatment. That happened in December of 2023. So we're probably going to have a complete data set for this in the next few years and be able to evaluate this a really excellent, large, long-term data set of treatment with this drug and see how it does in the kind of a 5-year window instead of just a 2 or 3 year one now.
Are there any factors that make this treatment more successful?
I think what we know specifically in terms of who does better is that what I spoke about earlier is that the ones who do not have center involvement yet, those tend to respond even better and have a bit more of an effect, and that is intuitive because those are the faster growing lesions in general. We know that from previous natural history studies as well. So that's the only distinction I would make in terms of who would respond better to the drug is the people who actually don't have complete involvement of their center point of their vision.
Do you have any advice for patients considering this treatment?
Yeah, I mean, I think that, it's important to have a complete conversation about the risk-benefit ratio of starting this treatment. It's not a kind of a slam dunk, you must be treated with this. It's one of these things where you can talk with a doctor, read the materials, go home, think about it, and then decide what you want to do from there, because it is one of these things where it requires a lot of visits. Probably every 2 months you're going to have to come in for the rest of your life. It requires you to get a shot in your eye every 2 months. It requires you to, and also patients have to understand that you don't get any visual benefit from this. You don't see better from this. You actually are just trying to preserve what you have for longer. And it also doesn't stop the progression altogether. Again, it's just trying to slow it down, give you as much time as possible with the vision that you have. So there are a lot of things to consider with respect to the risks, the benefits, and the overall kind of treatment burden. And so that all needs to be had. You have to have a good conversation with your doctor and go home and read the materials before you make a final call.
As always, thank you for sharing this information.